Bueno, vamos a continuar con la presencia del profesor Alberico Catapano, que nos da mucho gusto y placer. Acá tienen proyectado en inglés su currículum, yo lo voy a leer en español para todos ustedes. Alberico Catapano es director del Centro para el Estudio, Prevención y Tratamiento de la Atherosclerosis de la Universidad de Milán en el Hospital Bassini. Es director de la Unidad de Investigación Cardiovascular en el IRCCS Sesto San Giovanni Multimedica. Presidente de la Sociedad Italiana de Terapia Experimental y Clínica, presidente de la Sociedad Italiana para el Estudio de la Atherosclerosis y presidente de la fundación de la misma entidad. Presidente de la Sociedad Europea de Atherosclerosis, la IAS, que estamos nosotros muy vinculados, coordinador de la red de clínicas de lípidos de la IAS y co-chairman de las guías para el tratamiento de dislipemias y de papers de consensos de lípidos reportadas en conjunto con las sociedades europeas de aterosclerosis y de cardiología. El profesor Catapano se interesa por el estudio de la aterosclerosis, los lípidos, las lipoproteínas y las dislipemias genéticas, y ha realizado observaciones históricas sobre las proteínas de choque térmico y las pentraxinas, o pentaxinas que también decimos, en la aterogénesis. También sobre HDL en la modulación de la respuesta inmune y sobre la identificación de posibles targets terapéuticos mediante la incursión de información genética. Actualmente es codirector de Atherosclerosis del Journal y editor asociado de otras revistas o journals como el European Heart Journal. Es autor de más de 650 papers científicos en revistas con referato, con un promedio de índice de factor de impacto de casi 11, posee más de 80.000 citaciones desde 2018 para acá y 170.000 en su carrera. Y figura entre los científicos más citados desde 2019 a 2022, según el Clarivate. So, welcome, Dr. Catapano. It's a pleasure to have you here with us. And Pablo, you...
Agrego a lo que ha comentado Laura, que es la primera vez que Alberico conoce Argentina o viaja a Argentina y ha venido especialmente a nuestra actividad para estar menos de 24 horas con nosotros, así que es un esfuerzo grande el que ha hecho él para poder hoy compartir nuestra sesión. La modalidad de la siguiente actividad va a ser, el doctor Catapano va a dar su primera disertación, vamos a tener una serie de preguntas y respuestas y luego va a dar su segunda disertación para culminar también con una serie de minutos para responder preguntas y respuestas. La primera disertación va a referirse sobre las guías de lípidos, hechos y desafíos. So, Alberico, thank you very much.
Thank you. Sorry, I can't speak Spanish, but I can understand it a bit. So I will speak in English. First presentation today is on guidelines, and this slide here depicts my potential conflict of interest. Now, what I wanted to discuss with you is where we stand with the guidelines for lipids, taking as reference the European Atherosclerosis Society ESC guidelines, and what are the bases that have driven those guidelines and what can be the challenges and the possible future options. Now, first of all, one of the mainstay for the guidelines is LDL is causal to cardiovascular disease. This has been shown over and over, and I don't need to enter that. So it's not just a risk factor, but causes the disease, which makes quite a difference. And those are the main principles for LDL lowering therapy in the guidelines. That is, trials of LDL lowering indicate relative risk reduction is proportional to the absolute reduction in LDL. So the more you reduce the LDL, the larger the benefit. Doesn't matter where you start, is the amount of cholesterol that you remove with treatment that makes the difference. Lower is better, yes, because of this. The lower you go, the larger will be the reduction and more benefits you will bring to patients. And finally, intensity of LDL lowering should be based on risk. Why is that? It's based on the concept that percentage-wise, each millimole reduction of LDL cholesterol, you get a benefit in atherosclerotic cardiovascular disease of about 23% reduction. However, this is a relative risk. In absolute terms, the higher the risk, the larger will be the absolute benefit. So population at high risk will benefit in absolute terms more than population at lower risk. And this slide here depicts the concept. Just to make a long story short, you classify for the risk, and please note that we had a high and very high. Actually, we had also subpopulation here of people with very frequent events after the first one that we call the frequent flyers, extreme risk, where the goal has been set to 40 milligram per deciliter, so roughly 1 millimole. High risk, 8 millimole, 70 milligram per deciliter. But please remember also the other goal is 50% or more. Why is so? Because in one side you want to reach a goal proposing to arrive to lower levels to increase the absolute reduction of LDL. In the other hand, you want to make sure that even people starting at relatively low LDL, let's say a person having naturally an LDL of 80 and being at very high risk, you want to reduce more than go to 55. That is only 25 milligram per deciliter. You want at least 1 millimole, and by reducing 50%, you can achieve that. So what are the future challenges? First of all, how we detect, especially in primary prevention, free living population without having had a myocardial infarction, the risk. Well, these are the score tables. There are also score 2 and you name it. But the real problem you can see immediately here for guidelines and for us is as you grow older, inevitably, it doesn't matter how high is your cholesterol or non-HDL as with the score 2, how high is your blood pressure, you become a very high-risk person. And that's because of age. But that's not really prevention. That's just treating for the next 10 years what is happening. So obviously people will be a very high risk if they are 70. The likelihood that they will die in the next 10 years is much higher if you were 30, even if you were to have a high cholesterol in this area, you see here. But the 10-year perspective for these people is very low in terms of risk. So that's something that pushes treatment towards the elderly and doesn't take into account people at relatively young ages. In the current version of the prevention guidelines, they try to cope with that somehow, making this kind of curve here, if you wish, for the high risk. Being the high risk threshold much higher, about 17, 16, versus 7, depending on age. That means you become automatically very high risk if you have above 17, but you are at high risk if you are below 7. In this way, you redistribute a bit the risk among the people. But that's not enough. It's not enough because of this. If you look here, this is from our consensus on LDL cholesterol causality. This is the line of randomized controlled clinical trials. This is population study, and this is Mendelian randomization studies. Now, 1 millimole reduction, you get the usual 22 to 23% reduction of the events. However, this is for 5 years. If you were to look at the population level, 12 years follow-up, the same reduction will bring about a 34%, 33, 34%. Even more for 52 years of observation in Mendelian randomization, where you get a 55%. What is that telling us? It's telling us that if you were on therapy for a long time, you get a larger benefit, or you can get the same benefit with you have with 1 millimole reduction, with 0.4 millimole reduction, even less, if you were to keep that person on a therapy that lowers by 0.3 for 52 years. And that changes the concept of prevention. So you can start early with lower reduction of LDL without always the need to put people on drugs. 0.3 millimoles is about 15 milligram per deciliter. That's achievable with lifestyle changes, with dietary changes, and other means that not necessarily are pharmacological approaches. And this is the concept that becomes out of that consensus, that's a cumulative exposure. In other words, what matters is not the value at that day of LDL cholesterol, even blood pressure, or also glycemia you have, but what matters is how long you have been exposed. So the longer you are exposed, the more damaging will be the same amount of cholesterol. And this is the case of FH, familial hypercholesterolemia, where we know we can change the trajectory toward the disease, taking heterozygous patients, starting early with therapy. We have now this data. You can change the trajectory of these people towards the disease almost to a point that will get to the disease at age that is for the normal population. The other point is this one nobody is able to take in account so far. We'll see if we could in the next few years. That is genetic predisposition likely to produce a combination of genes, and genes and environmental factors causing particular traits that may vary from person to person. And that has to do with the epigenetics and all this. We are collecting all this information out there. Everything is in the cloud. How to use that for predicting risk is still in the clouds, but is something that we'll have to face. And this is why we have at least, now it's 196 genes that are related to the disease, by GWAS, for instance, and yet only of a few of them, about 45, we know what they do. The other ones, we don't really know what they are doing. So we need to explore that further. HDL. We have been told HDL are protective. Doesn't appear to be the case. It appears as if HDL have a sweet point, that is this one in the population, where at the level around between 40 and 70 in males and a little bit higher in females, the risk is relatively low, but then in both sides of the distribution, the risk increases. This is true for cardiovascular disease, it's true for infection, it's true for all-cause mortality. What this is telling me that HDL is an epiphenomenon is the association that has been shown is because we had data cutting here with Framingham and other epidemiological study. And as a matter of fact, saying HDL is protective is difficult from this data. Nevertheless, HDL probably will fade away from guidelines, as we already suggest not to take them in account, but to take them for the risk at low levels. What to use, non-HDL or ApoB in everybody? Well, you know the story of the remnants. This is quite an oversimplification because what has been named as remnant is essentially VLDL cholesterol because it's calculated as a difference. However, it is related to risk. But if you do Mendelian randomization, this is a paper we published with Brian Ferencz a few years back, ApoB, LDL cholesterol, and triglyceride, all of them are associated individually. But if you make a multiple variable analysis, then ApoB is the only one that stands up, suggesting that yes, triglycerides are related, yes, LDL cholesterol is related, but what counts more in the population is the ApoB. Of note, ApoB is just one per each particle in VLDL and LDL and recapitulates probably all the information about atherogenic lipoproteins. That's why it's overseen in the others. Shall we determine ApoB instead of non-HDL cholesterol? Well, could be. Certainly, there is more information in non-HDL cholesterol and ApoB, especially in patients with high triglycerides, so in people with diabetes, metabolic syndrome. And this has been shown, the ApoB, to be superior, also from this analysis of first MACE in patient with Ariocumab, Odyssey, when the data are cleaned from the level of LDL, the effect on LDL cholesterol. Still, there is a relationship on the reduction of ApoB, meaning that ApoB adds information also in clinical trials, in the outcome of the clinical trial, if you follow the ApoB reduction. LPLA, we will see in a minute, so I will just say a few words related to cardiovascular disease related to aortic stenosis. Let's forget about these slides because I will present that later. Consensus panel recommendation, we published that last year. In absence of specific LPL-lowering therapies, traditional risk factor management is recommended. And a variety of LPLA patients with a high LPLA should be considered. Should that enter the guidelines? I think yes, and there are trials ongoing, and we'll discuss LPLA in a minute. Percent reduction versus goals. Again, as I said, our guidelines suggest clearly that there should be goals as well as percent reduction. This is for the very high-risk population. But we also have non-HDL, we also have apolipoprotein B. And this is because what I mentioned to you, not only achieving the goal, but also a certain amount of reduction. Please remember that the goals are set to promote more intensive therapy, are not something that is written in the rock. What matters really is how much you reduce LDL cholesterol. So the larger the reduction, 2 millimoles, 3 millimoles as compared to 1, the larger the benefit. The goals are only there to push you to be more attentive, to be more intensive with therapy in people at high and very high risk. And that's reflected here. Stepwise approach. There's been a lot of discussion about this stepwise approach proposed in the guidelines. The guidelines cannot deviate from evidence, and the evidence depends on the randomized clinical trial. Those are the rules. And obviously, it makes it difficult to say statin in combination with ezetimibe because the evidence there is one trial as compared to 20 or 25 with the statins. And that has spurred some discussion. However, guidelines are made to reflect what is the guidance with some rules, but in clinical practice makes sense to start immediately with a combination therapy if there is the need to achieve a goal and you are far away from that point, especially if you have a very high level of LDL cholesterol. So I think in future guidelines there will be, as it's already here in these guidelines 2019, if you read carefully, it's written, if you are more than 50% away from the goal, consider combination therapy. However, cannot be put up there in frame immediately. So that's a challenge, but probably we will have to take care of that. And we already started, not with the guidelines, but a sort of consensus paper indicating that. We have the guidelines, but in reality, guidelines are poorly applied. This is the Da Vinci, but also the Santorini trial showing more or less a similar point. Very few patients are taken to goal, not because we do not have the drugs that are effective. I'm old enough to remember I had only clofibrate and cholestyramine when I started. Both of them did very poorly in controlling LDL cholesterol. Now we have a number of very effective drugs, but still we don't use them at the maximum possible efficacy. So we need to change that. And it's not only the availability of the drug, the way we use them that makes few patients to go to goal. Is that an issue? Certainly, because we reduce LDL cholesterol less, and by reducing less LDL cholesterol, there is less benefit. And this is the proportion of patients at goal, if you look here. Then this is the Santorini trial, more recent. And there has been a change that may be encouraging, if I'm an optimist by nature. More people are getting into combination therapy, starting from a low percentage, they got to goal 10% more at high and very high risk, as you can see here, by using more combination therapy. And this is more contemporary study, the Santorini. And you can see here the usage of these drugs. As I said, combination therapy is becoming more and more used in a clinical practice, while monotherapy is increasing, but because of this. This was the entry, and this was after 1 year. This is follow-up of 1 year. The Santorini, which is a peculiarity, is not just one shot, but it's twice look at the same patients. Adherence to therapy, then, is the last problem with the guidelines. Necessarily, guidelines are not giving you any specific mean to improve adherence, but I like to show this slide because it's very old, this study, it's 2007, but you can see immediately, this is adherence to statin. On the top, above 80%, here 40 to 80, and here less than 40%. This is total mortality. It's not just cardiovascular, overall total mortality. And you can see here, this delta here is exactly the same in the 4S study, 41%. That means in the 4S where they were on placebo, really, with the statin, and they decreased the statin, they were taking the drug, they got the same benefit as being adherent to therapy. So you can repeat the trial also in real life, if you will, having people not taking the statin or people taking the statin here in terms of having the effect, and you see that 41% reduction in total mortality, which was the primary endpoint of the 4S trial. To close this first presentation, I wish to remind you that we will go to Lyon next year with the European Atherosclerosis Society, and I'm here speaking on behalf also of the European Atherosclerosis Society. So thank you very much for your attention.
Thank you very much, Alberico. ¿Hay alguna pregunta? Alberico, regarding LDL cholesterol, non-HDL, and ApoB, do you think that we have enough evidence to move to ApoB or non-HDL and put LDL below in the second place in the next guidelines?
I mean, if you look at the guidelines, we already had the ApoB in the 2011 guidelines. And we kept suggesting them only for people with high triglycerides, relatively high triglycerides, between 170 and 250. Why? Because ApoB outperforms LDL cholesterol only if you have VLDL increased. Otherwise, it's exactly the same. Second, still there are people who do not measure LDL out there, and I think making that kind of change, albeit scientifically sound, will just make a mess. So I'm convinced that if we stay with the LDL, try to get it implemented, and the vast part of the benefit will become by reducing LDL. Then we can discuss, as an academic discussion for the moment, let's discuss about the ApoB. Theoretically, it could go there, but I don't think using that in clinical practice, unless you are in a specialized center, it's going to help.
We have a question. If anyone have a question, I can.
And what do you think about, because with these new drugs, you can go with LDL cholesterol below 20, 15, or even less than 10. So if you apply the Friedewald formula, it's very inaccurate. Do you still think that we can use Friedewald formula in those patients with very, very low levels of LDL cholesterol?
No, when you go that down, you need to change, because you get results that are not credible. So in that case, ApoB or non-HDL could help.
Dr. Lorenzati, afterwards I will do another question.
Thank you, Dr. Catapano. You mentioned adherence, you mentioned other causes of low achievement to the guideline target. But we have globally, I mean, because during the ESC Congress, the Inter-Aspire trial results were presented. For example, data from Latin America, the achievement to the European guidelines in terms of LDL reduction was very low, more or less 20%. The problem is the medical doctors' inertia. Do you think we have, I'm glad to hear from you to insist with the causal effect of LDL on atherosclerosis. Do you think it's a matter of lack of deep comprehension of the doctor regarding the problem that we are dealing with?
I mean, taking people at goal means you need several things to be all together and work together. Certainly, colleagues do have issues because they tend not to use the maximum doses, and those are coming from concepts about statins, but not only about that. In general, using a dose that is not the maximum available dose means fewer side effects in their mind, less troubles, patients coming back. And they want to stay on the safe side. Second is correct. Many people yet are not convinced that lowering LDL that much is trouble-free. Many people still think there may be trouble in going down with the LDL. Albeit we know is not true, but that's difficult to change this attitude. Third, patients. They don't like to take drugs because of what is in the newspaper. And fourth, the economic system. I mean, statins are reimbursed almost everywhere, I suppose, and they're cheap if you want to buy it. But then when you move to the combination therapy, prices start to increase. Now, combination of ezetimibe with statins is almost the same as a statin, a generic statin. But then if you have to add another drug, that the cost will increase. And depending where you live, that will be a problem. So there are a lot of obstacles. Some of them can be taken and challenged with knowledge. Some of them depend on the economics. Some of them depends on perception. It's difficult to put everything together. Yet, we could do better. I think we could do better.
Well, is there any other question? No. From your point of view, which is the best way to report the lipid panel regarding reference values or normal values? No. If the classification, risk classification and goals?
I mean, the problem has been there since decades. We started in the early 90s discussing with the clinical chemistry people how to report to the panel for lipids. The problem is they do not know the patient, they know the numbers. So they cannot say high risk, low risk, because they don't know the patient. And that's already first something that doesn't work. But they can put a sentence saying, talk to your doctor because the numbers are different according to risk. However, it's very difficult to eradicate the concept of normal from the mind of people in the laboratory. For them, normal means the average in their population. So if, for instance, they were living in Quebec, they would have an LDL normal of 200 because it's full of familial hypercholesterolemia people there as normal, because that's what they see as an average there. Living in some place in Africa, for instance, a normal LDL would have been 60 or 65. So that's a problem. What is normal in terms of statistics in population and what is normal in terms of biology. And what should be there is what is normal in terms of biology, what is normal for that population. And that's only the doctor can do that. It cannot be done by the lab.
Thank you very much, Alberico, for your excellent presentation. We can move on to the next lecture regarding Lipid. La próxima presentación del doctor Catapano va a referirse a LPA, una mirada al futuro. Alberico.
Okay, so I jump through the Lipid because I'm going to discuss with you Lipid for a second. I think this is something that is quite stimulating because there is a lot of turmoil around Lipid recently. Again, my conflict of interest. And this slide, just to summarize for you what is an Lipid or how it should look like, is a particle that resembles an LDL, at least in terms of size, for this part here, and composition, and by the fact that the ApoB 100 is there. So it's similar to LDL, not an LDL-like, though similar, but not like. In addition to that, there is a bound with this sulfide bond here, a molecule named ApoA, a protein, that has several characteristics and has the characteristics of being high polymorphic. This kringle here, this structure, protein structure here, kringle 4, 2, is repeated from 1 to more than 40 times. So you get an ApoA that has a large variability in terms of size. And that's what an LPLA is. Similar to plasminogen, but doesn't have as a protease domain, but is not active. So it's not active in terms of working on plasmin and so on. What is the distribution of LPLA? Well, that's another interesting point because it's very much skewed. In Europeans, it's like this. Females do have higher levels of LPLA as compared to males. But also, if you look at people who, black individuals here, that's the distribution. So it's quite different from that in white persons. And it's also true for other ancestries. So there are distributions that are not exactly the same. And the fact that it's so much skewed reminds perhaps triglyceride distribution, you see here, but there are very few people with high levels of LPLA as compared to people with relatively low or very low levels of LPLA in terms of normality in the laboratory. It's synthesized by the liver, yes, because the ApoA is made in the liver. Whether ApoA associated in the hepatocytes or immediately upon secretion is not completely clear. Then once in this blood is removed, returning to the liver with number of receptors potentially involved, the asialoglycoprotein, SRBP1, the LDL receptor itself, potentially involved, as I said, in this removal. Half-life of LPLA is longer than that of LDL. It's about 3.5 days as compared to 2.5 days for LDL. It's causal to disease. Mendelian randomization indicates, yes, it's causal to cardiovascular disease. Is causal, I will see in a minute, to other disease, but certainly for aortic valve stenosis on calcific basis. So people with high LPLA tend to have more frequently aortic stenosis. It's not a risk factor for venous thrombosis, so it's nothing to do with the activity on plasmin and etc. And it appears as if a very low LPLA may associate with type 2 diabetes. What are the mechanisms by which LPLA linked to atherosclerotic cardiovascular disease? This slide depicts for you the complexity. People think oxidized phospholipids that are accumulating in this pocket here may be the trigger. Most of them are here and also in the lipoprotein itself. However, this is the number of possible pathways that have been suggested for LPLA to be causal to the disease. When I see so many things around, that tells me we just need to know better what we are looking after because cannot be everything is there. So it's just an example of how ignorant we are about how LPLA works really. Certainly the hypothesis of phospholipids is one of the strongest one. Now let's look at the epidemiological and genetic findings. What is interesting for LPLA, you have variants that will increase LPLA level, ApoA levels, and variants that will decrease LPLA. And if you do Mendelian randomization studies, you immediately can see that if you get the variants that increase LPLA, you have an increased plasma levels of LPLA and increased risk. And there is a causal disease association. However, on the other hand, you can show also when you have variants that decrease LPLA, you have protected these people against disease as compared to the average population. So you have both sides with LPLA. You can show that if it's low genetically, you have lower risk. If it's high genetically, you have higher risk. That's even stronger information about the association. If you look at different population, like the UK Biobank, and these are the data from our consensus, these are data I made with Brian Ferencz, you can see here, the correlation with myocardial infarction is quite strong. With aortic valve stenosis, you see here, is quite strong. It's less powerful with ischemic stroke and heart failure. So these two are the main areas where Lp(a) is impinging in terms of relationship based on population studies. It's true also in people with different ethnicity, in black individuals. Yes, obviously this is again from the UK Biobank. Here the number is 7,000, here is 400,000. And obviously the interval of confidence around the curve here is much larger because of the low number here. But the shape of the correlation is exactly the same, indicating that even in a population where the distribution, you remember, is different, because in black people, the distribution was much wider as compared to the white people, still the shape of the correlation is the same, indicating that are the levels that dominate, not the type of distribution. And if you analyze in terms of levels, you can see the risk of the people at the same levels of other risk factors. This is the population median, about 7 milligrams per deciliter in UK Biobank, then 30, 50, 75, 100, 150. I should talk in nanomoles per liter because of the heterogeneity of the protein, so that will be the best way to produce it. But many assays also give you the data in milligrams per deciliter, which is not the best possible approach. But nevertheless, you can make a sort of transition from milligrams to nanomoles. And you can see here, higher the Lp(a), higher the overall risk, and this is in age from 40 to 80 years of age. So you can see here how the cumulative exposure to high levels of Lp(a) will increase your burden of disease. It is a risk factor even at low concentration of LDL. There were suggestions that Lp(a) was cross-reacting, if you will, with LDL cholesterol. So higher the LDL, then the Lp(a) could contribute to the disease, but it's not the case. Even when you have low levels of LDL, Lp(a) stands alone. And what is missing for Lp(a) as compared to LDL in terms of causality? We need the clinical trials. We need the clinical trials that are ongoing. Without that, we'll be missing one of the key points for causality, that is having had a clinical trial. Thromboembolic events, as I said, are not associated, and that's, again, from the UK Biobank. So you can rule out venous thromboembolic event as one of the diseases carried with Lp(a). But if you look at diabetes, as I said, this is the meta-analysis that Samyamura made for the consensus. You can see here, it appears as if there is an increased risk of diabetes mellitus. That doesn't mean there is a causality there, but it's something that needs to be explored. Aortic valve stenosis, boom, you can see here, it's very strong. As strong as with atherosclerotic cardiovascular disease. So again, that's why we suggested this for Lp(a). Testing and measuring. I mentioned to you milligram per deciliter versus nanomoles per liter. Why is it important to have the nanomoles? Because heterogeneity of ApoA. ApoA can be small or large in terms of repetitive Kingel-4 units, you see here. Then if you do an assay that relies upon an antibody or a polyclonal antibody that recognizes multiple sites, like here, or a monoclonal that recognizes areas that are repeated, you get the wrong value as the number of repeats increase. However, if you were able to detect ApoA only for a single epitope on ApoA that is not repeated at all, then you can do it. Assays like these are available now, so with this kind of assay you can give the numbers in nanomoles per liter, and that would be the measurement of the number of molecules that are present. So there are other issues, yes. The fact that there is a fluctuation. We always suggested once in life, because we say that it's genetically determined, but meaning 95, more than 90%, almost 90% genetically determined. But when we say genetically determined, we make the extension to the value in plasma, which is not the case. Genetically determined means if you have a high level of Lp(a), genes are in agreement with that, and the same for low levels. But that doesn't mean that the actual value of Lp(a) will be exactly corresponding, and there may be fluctuations there. Maybe fluctuation because also Lp(a), specifically Lp(a), is responsive to inflammatory stimuli. It's not an early phase protein for a response to inflammation, but as a long-term response for even more than a month. So you can have increases of Lp(a) after an acute phase, even after an acute coronary syndrome. So there may be variations there. People should know. And that's why our list once in adults measurement perhaps is not the best suggestion. We should reconsider that and probably make sure that this is determined more than once. How to incorporate Lp(a) in risk estimation? And this is very interesting because if you follow me, what appears to be difficult is quite easy. Now, if you were to plot here baseline categories based on traditional risk factors, 5, 10, 15, 20, 25% risk in given years, 10 years, let's say. If you plot here the levels, plasma concentration of Lp(a), and here the risk of events, you can see immediately there is this kind of relationship. So high Lp(a), high risk, high level of events. And that means that if you were to have high Lp(a) here, but low risk, this is the numbers of risk here. You can see here, 8.6. With a low risk, it's 8.6, which is less than having a risk of 25 here. So those are the changes that occur. And there is interaction between Lp(a) and the risk, like LDL. So there is no value above or below with which you can say Lp(a) is high. It depends on your risk, like for the LDL. And that's very important because it means that you have to consider where you stand with the risk, also when you measure Lp(a), and your intervention should be, as we do with the LDL, determined by the global risk, not only by the level of Lp(a). And you can see here the rate-fold increase. Risk here goes from 25 with a low Lp(a) to 61%. But if you were here and you go to 150, the increase is high, but still is very low, as compared to other here, who have a 25 of risk with a low Lp(a). Managing Lp(a). In the absence of specific Lp(a), we have recommended to decrease the other risk factors. You can do that. Among patients with high Lp(a), all cardiovascular risk factors should be comprehensively addressed. And this is the example. This is the line of risk, the blue one, for the reference group. Low Lp(a), LDL cholesterol, that's the average in the UK Biobank. These are data we have made it together from the UK Biobank with Brian Fiennes. Then you take these people here who have exactly the same LDL cholesterol but high Lp(a), and that's their risk lifetime. So you see a huge difference here in terms of events. Now, what happens if you take the population with the same Lp(a), more or less here, but you decrease LDL by taking the population with 3.1 millimoles? So this is a 0.5 millimole difference. You see the curve here? Superimposable. Meaning that, meanwhile, we have no way of reducing Lp(a). If we were to reduce further LDL, will bring a benefit and will somehow cope with the excess risk that's contributed by Lp(a). That doesn't mean we are taking away the risk that Lp(a) contributes, but we are further reducing the risk by reducing LDL. However, this has limitations because, yes, you can do that when you have an Lp(a) at that level and LDL cholesterol at this level. However, if you were to have an Lp(a) at that level and you have to change cholesterol, LDL cholesterol, to reduce risk, you will end up with a reduction of 2.3 millimoles, and many times you are not able to do that. So still, there will be patients where you cannot wipe up, if you wish, the risk contributed with Lp(a). So early risk factor management is recommended, but still has limitation. However, we have drugs. Lipoprotein apheresis can be considered. Niacin is not recommended. The consensus points, as I said, are there. Statins, this is the largest meta-analysis done, do zero. Some increase a bit, some decrease a bit, but in the end, they do very little on Lp(a). PCSK9 inhibitors, yes, they do decrease Lp(a). What is the benefit carried by this decrease of Lp(a) is difficult because it's expressed percentage-wise. In the trials, the starting point with Lp(a) was in the range of 10 to 15 milligrams per deciliter, very low. So 20% of 10, it's 2. Is that going to count clinically? I'm not sure about that. Inclisiran dose more or less the same. We have new drugs, pelacarsen, olpasiran, SLNN 360. Some of them are ASOs, so antisense oligonucleotides that work at the level of the nuclei, or the others are small interfering RNA that engage with the risk complex. Those are long-lasting, up to 6 months efficacy for single dose once reached the steady state. And these are less long-standing, 1 month repeat injection. They do work well, yes, they do. The Horizon trial that is made with an antisense, with pelacarsen, these are the population chosen, above 70 milligram per deciliter of Lp(a) as a minimum, and that's where the population has moved with 80 milligram of pelacarsen. So there is a huge change, and if there is an effect, we will see it. Olpasiran, small interfering RNA, is even better in terms of reduction of Lp(a) than pelacarsen, and you can see here the reduction about 95%. Many trials, phase 1 and phase 2 and phase 3 have been reported, and the trial started already. Phase 3, both in terms of events, the randomized clinical trial, RCT, then phase 3, and then the SLN 360, again reported recently last year, 100%, in some cases 105%, depending on the calculation as compared to the control. Very effective, both small interfering. Recently, lepodisiran has been reported, small interfering RNA targeting Lp(a). This is, the data have not been reported, but the trial is ongoing. And muvalaplin. This is a drug that is given, that is not an antibody, but is targeting ApoA, so binds to the ApoA. It's similar to the mechanism of action of the drug that Merck has made for PCSK9 inhibition, which binds PCSK9. What matters here is the affinity of the drug for the binder here. For the PCSK9 inhibitor is the order of 10 to the minus 11. That means binds completely and very sticky. For muvalaplin, it's a little bit less, but still it's quite good. However, when you look for the reduction, look at this part here, percent concentration. This is the drug, so it's not a small molecule in real terms. The molecular weight is higher than 300, so needs to be somehow helped in being available. You can see here the reduction, and the reduction ends up and plateaus around 60 to 65%, which is by far less than what has been shown with small interfering RNAs. So whether this approach will compete with the small interfering RNAs is difficult to say. Certainly it's less potent and effective. So in conclusion, increased LPL levels are associated with the risk of atherosclerotic cardiovascular diseases and aortic stenosis. LPL levels are mainly genetically driven, but not completely determined. And specific therapies are coming that will allow us to understand whether LPL will play a big role in reducing risk or will have a small part of the pie. Before I close, let me remind you of other activities that our society is doing. One of them is putting together the societies, the friends of different societies of atherosclerosis throughout the world, and also with the lipid clinic networks, making a network among lipid clinics worldwide. and you are part of that network. Thank you very much for your attention.
Questions? I have some thoughts, or I was wondering that although or despite all the problem in measuring LPA, especially 2 decades ago, if we have to use or no frozen samples, the antibodies that we implement in the assays. But we have a lot of information, even although there are a lot of problems in measuring and with the frozen samples and all that problems. And we manage today, all of these are consequence from all the experience from the 90s or before.
Now, as usual, things get better when there is someone spending money around that. And the situation is now repeating. I mean, companies all of a sudden have discovered that LPA is important. They are putting money in the trials, obviously, because they are developing drugs. But at the same time, there are fringe benefits. They realize they need to have a better assay. They realize many other things. So that will put together. The cost of the assay will go down dramatically. The assay will be the right assay, which has not been developed. Only one assay was developed towards that by Santiza Markovina in Seattle with the CDC, but was not available to everyone because it was the standard. Now they are developing a mass spectroscopy assay that is more stable than an antibody as a reference material. And there are drugs, and that inevitably brings the interest. So the field has been waving a bit, also because there was a lot of uncertainty until recently on the correlation, firm correlation of LPA with cardiovascular risk. There were a lot of discussion. Is an additional risk factor, is contributing when you have a high LDL. That was taken from the story of people with FH, showing that people with FH, with high LPA, had higher risk. But you can look at the thing the other way around. They are more at risk because there are 2 things instead of 1. So now things seem to be better, and I'm positive that will be possible. We'll have to see who will benefit from the reduction. I didn't discuss that for the lack of time, but the amount of reduction of LDL you need is of LPA is much larger than the LDL in terms of % reduction of mass, because the correlation is very large. It goes from 0 to 1,000. For LDL, when you have it, is from 50 to 200. So it's completely different in terms of how much you need to decrease. Sorry.
Well, first I'd like to congratulate you for your excellent dissertation, and then I'd like to ask you why very low levels of LPA are associated with diabetes.
Sorry, I didn't get the question.
Why very low levels of LPA are associated with diabetes?
I wish I knew. I don't know. A very simple answer.
Thank you very much.
Alberico, as you know, since statins could rise Lp(a) levels 10, 15, or even 20% in daily practice, do you think that this effect could affect patients regarding clinical events?
I mean, as I show, if you make a meta-analysis, there is not much an effect of a statin, but that's because the meta-analysis covers for all types of statins. If you were to use the more potent ones, you see an increase. That's sometimes maybe as much as that, but the meta-analysis is around 7 to 8%. I don't know if that's statistically significant in terms, significant in terms of handling of the patients. 8%, again, 8% of what? You see what I mean? Because if you start with the average LPLA, that is 7, 20% of 7 is 1.4.
So in the clinical practice, if you have a patient with very high levels of LPLA in secondary prevention...
But it doesn't go, that's the concept. If it's a high level of LPA, it doesn't increase that much after start. It increases when it's rather low.
Okay.
Para no molestar al doctor. Gracias por la conferencia que fue excelente. Yo soy pediatra y tenemos pacientes con valores muy altos de LPA, asociados a veces a accidente cerebrovascular. Algunos de ellos hemos tenido medicado con ácido nicotínico, uno solo que respondió y toleró la medicación. Y en algún paciente muy severo también hicimos plasmaféresis. Pero recibimos consultas o derivaciones de familias con LPA muy alta, con antecedentes de personas jóvenes en la familia con accidente cerebrovascular y que no tienen factores de riesgo, con valores de 300 nanomoles por litro. Entonces, ahí, ¿cuál sería el nivel de LDL al que uno querría llegar? O, bueno, por ahora mucho más no tenemos que hacer para hacer más que, bueno, peso, actividad física, etcétera, pero...
The question, Alberico, is Maribel Araujo, she's pediatrician.
I understood almost everything, but...
You understood? Okay.
Maybe I missed one or two.
No,
I understood that she has a patient with...
Yes, pediatrician patient with very high levels of LPLA, with cerebrovascular events, and she wants to know which is the level of LDL cholesterol you have to reach in those patients with very high levels of LPLA and familiar events of cerebrovascular.
I mean, it's not infrequent. I mean, people is not looking after it, but it's not infrequent, the observation of family clustering with a high LPLA. It's not infrequent. How much to reduce is as much as possible the LDL if you have this level of LPLA. If you have available LDL apheresis for the time being, that's another way to do. But I'm pretty confident that the drugs will be available soon, so perhaps you can treat that. But it is quite frequent in people without any other known factor that contributes cardiovascular disease to find high LPLA in the family. And there are several families with, this trait of high LPLA. And that should be treated. Obviously, you need to control. In kids, it's almost impossible. There are no other risk factors, obviously. I'm not sure there is enough evidence to treat the kids at the moment. I would wait a bit until they turn around 14, 16 and see. At that time, you will get probably the drugs to be able to treat them.
Gracias.
Thank you, Alberico. Bueno, estamos en tiempo. Les pido un segundo más. Facundo, por favor. We want to share with you a present for our society and for our members. Facundo is one of our...
Thank you very much.
Please open.
Yeah.
This is our present. We call mate. It's a classical infusion here in Argentina.
Thank you.
Thank you. Thank you, Alberico.
Thank you.
Pleasure.
Thank you very much. Thank you.
Bueno, nos quedamos para el lunchbox y la presentación de los trabajos y lo despedimos entonces al doctor Catapano, que en unas horas regresa a su país. Thank you very much, Alberico, again. Thank you.